So I'm going to have everyone introduce themselves, and let's get into it.
Well, I am Dr. Celia Egan. I'm the internal medicine physician and the director of obesity medicine and metabolic health at True Women's Health, and now a partner with Together Women's Health. Like Dr. Bitner, I'm equally excited to be able to work with the patients of Together Women's Health practices to provide them care both with hormones and weight loss and some direction in all things metabolic health.
Cool.
Hi there. My name is Anu Vasadia. I'm a physician with Paint Creek OBGYN, actually the practice medical director there. And we have been partnered with TW, Together Women's Health, now for 3 years. And so I'm excited to join this exciting talk today.
Awesome.
And I am Paula Fishbaugh, and I am an OBGYN with Women First OBGYN Center in Royal Oak and Birmingham, Michigan. And we have been with Together Women's Health for about 2 years now.
Awesome. So I just want to give a quick background of True Women's Health and why are we partnering together. So I'm an OBGYN. I've been in practice 30 years. And about 10 years ago, I got really interested in midlife and menopause because patients would come to me and have fears about hormones or not, ask questions that I couldn't understand. And so I really fell in love with helping women with these questions and decided to do it about 5 years to do it full time. So I stopped delivering babies and doing surgery and started True Women's Health. And so really got comfortable with hormones. I developed a clinical process, wrote a book, published some papers, became really involved with the Menopause Society and the International Society for the Study of Women's Sexual Health. And then was able to bring Dr. Egan on board, thank goodness, and together looking at metabolic health and GYN menopause health, we were able to form True. So True is a brick and mortar. It's an office in Grand Rapids, and we just want to reach as many women as possible. And so we're super excited about this opportunity to work with all the patients of Together Women's Health across the country as time goes on. And what we do is we celebrate and bring together these 10 areas of wellness. So 10 areas of wellness, meaning all the things that possibly a woman could experience as she's aging, meaning, is she able to be active? Is her body composition how she wants? Is her cancer risk where she wants? Is her heart health how she wants? So Celia, like when you joined True and now with Together, like what excites you the most?
Well, I think the most exciting thing is we're able to sort of provide answers to questions that sometime in the traditional primary care offices, I know definitely in like a family medicine or internal medicine practice, sometimes the doctors don't always have answers for, or the time necessarily to review all of the patient's options and encompass some of the lifestyle factors that come into play. So at our, wellness programs, we really like to emphasize that you get a lot of time to not only get your questions answered, but to talk about those things that maybe you just have never gotten a clear-cut answer to.
So as we roll out this Together Plus, it's a telehealth program. It's virtual, exclusively virtual, so we can reach as many people as possible. And you'll see that you can put in your comments. We really hope that this is a very comfortable, casual conversation, all things menopause. And so, I'd love to bring you guys in, and if you could talk about why are you excited about this? Like, what if opportunities do you see that this brings your patients?
You could go first.
We both went. So I know we all have those patients that we've tried, dabbled in a little bit of HRT or the alternative treatments. And you just kind of feel stuck where you've talked to them about all the options. Either they don't seem happy with the options or the options don't seem to work for them. And so I think you guys provide an outlet for those patients who aren't quite getting the answers that they want, and do more of a comprehensive, workup, from what I hear.
Sure. It's just so hard when you have a busy practice. Like back in the day when I was doing OBGYN, like in a busy office day, it would be really hard to take the time to do a real deep dive, I would think.
Yeah. And I don't know about you, Paula, but for me, I'll do the deep dive and then, 2 weeks later, they're calling back because they've rethought it. And it's like, nope, then you got to come back. We got to have another visit. You can't like do it over the phone because also we don't always remember every little detail that we talked about, regardless of what's documented on the chart. So yeah, it makes it hard.
Of course.
I think for me, a big thing is just because, I mean, it's amazing that in today's world, there's so much talk about all of this now, which I think is great, but where people are getting their resources and what they don't know. I mean, it'd be like me looking at legal stuff. I can read things, I can chat GPT it, I can look things up, and I can understand some of it, but I'm not going to understand it better than an attorney, right? So for me, there's all these other platforms like MIDI and all these things that I've had patients go to, and they tell me what they're prescribed or what the conversation was. And I try to not look horrified that it's not at all the right thing, but I try to gently explain this might not be the best option for you. And I don't know what they told you, but maybe we could go a different path. So for me, having you guys who are doctors that I know, that I respect, that I know you're not going to give them kooky supplements, and I know you're not going to just try to sell them something that I don't believe in. And so for me, I think that's a huge resource for my, like the doctors in my practice, because you don't really know who those other people are on these other platforms, and to be able to have a connection. And I feel like at this stage of the game with my patients, I've done this for a long time. So if I can say honestly, hey, I know Celia and Diana, and they're going to take good care of you because we've sort of hit this roadblock, or I think you need something additional, or, nothing about menopause is really cookie cutter. Everybody's different. Everyone goes through it differently. What works for your best friend isn't going to necessarily work for you. I think those are the really difficult patients where it's kind of like, we got to get you over this hump, but you've got to go to somebody who has more time and more knowledge on that other aspect of it.
Yeah. And even what's been interesting, even as I got really comfortable, with hormones and learning that women really want to know, number one, why they feel what they feel. And then, all the options and time to figure it out. There's just this metabolic piece as well. Learning that menopause is a pre-diabetic state was like an aha moment for me. Like, oh, that's why the weight gain. So like to have all of this together with our team, I think we bring a lot to the table to help your patients.
I would say one of my favorite parts of joining together women's health and working with your practices is our ability to communicate together. These are really potent, intense medications. They're incredibly effective at what they're doing, but the fact of the matter is patients can have side effects. And to be able to have that conversation with you guys as doctors that these women know and trust, I find just so invaluable, because if a patient's having side effects, we can all work together to figure out the next best step versus, I've gotten, even in our own practice, we've gotten phone calls from patients that, are coming to our practice because they just couldn't get answers from some of these other online programs. And so we really are hoping to provide this like synergistic care where you guys know the patients, we're here to provide some insight into these medications, and then together a woman can get exactly what she needs.
Exactly. Like sometimes they might be prescribed something and they had a 20-minute visit, and now they're prescribed a medication and they can't get a hold of the person that prescribed it, and the person might never see them. So they've got you guys to see in the office, do their GYN exam, be their stable person, and then we're consultants in terms of how much this is becoming a specialty all of its own, just like urology or MFM or gynec, right? Like this is its own specialty. And so I just love how we can work together.
Yeah, I agree. So I think it's a great resource, even just to bounce things off, even if we're not sending them right away, just to have you guys to kind of say, hey, here's where, this patient's complaint, or this is what I'm trying to do, and what do you think a next good step would be before I can get her off to you or something. And I appreciate that teamwork as well.
And it's amazing how quickly things change in this world. I mean, I go off to the Menopause Conference or the Sexual Health Conference or the International Menopause Society, and it's like, as new medications roll out, we're excited to be able to bring these new options to your patients. And so, I know you're hearing about them as well, but it's really cool to, work together to make sure it doesn't take a lot of time for our patients to get those options, because it can be a challenge to figure out how prescribing and side effects and cost and insurance and authorization and all the things, and we've just got that all streamlined. So again, everyone listening, I would love to see your questions or comments. Again, we want to keep this really comfortable and casual. And I guess one thing we could start talking about is what exactly is the program. Again, we like to think about this. So for example, when you go to Paula and you're 12 weeks pregnant, you know what to expect, right? Like you're going to get your ultrasound or whatever in terms of the standard of care. And wherever you might be, you'll get a similar program. So at Together Plus, same sort of thing. We start with a cadence, but we number one want to know, what do you want? What is your most bothersome symptom? What is your picture of self? And then, Celia, do you want to talk a little bit about the patient experience?
Yeah, and we're going to get to Tammy's question in just a second. So when, thinking back to the traditional kind of a primary care office, a lot of the times those visits are driven by, disease management, in a sense that I'm like, oh, this patient now has diabetes and I'm going to treat that diabetes as a internal medicine doctor or family medicine doctor. But what we're trying to do is take a step back and ask a woman sort of what her goals are and where she wants to get started in order to optimize her life. So it's really treating that woman sort of where she wants to be versus, kind of just treating different disease processes. And sometimes a woman's sort of symptoms and, even just her own direction can get lost in that shuffle. So when we think about a wellness program, we've broken it up to 10 areas of wellness that we'll work throughout over a year. And we want to make sure we touch on all the sort of topics that a lot of women are commenting about now, like weight, hormonal changes, cancer risk, bone health, sexual health. And so we really hope that a woman will feel heard and that all of her symptoms will be addressed to the degree that she's hoping to get.
Yeah. So when a person signs up for the program, what happens is then you get signed up, you get an appointment, and you'll get a package in the mail with a scale that looks at your body fat, your muscle mass. You'll get a book, you'll get a binder, you'll get a sex deck, which talks about all the reasons for low sexual desire. And then we get started. You might choose to start with the weight focus. You might choose to start with the menopause focus. And you'll see one of our providers. But again, you keep your doctor at the clinic, your physical exam, all of that is done with a doctor that you know and love. And then again, we can start along, but it starts with what you want most. And so you can certainly learn more about the programs. But I wonder, Missy and Samantha are behind the scenes and they're going to pop up these questions so we can address them. Maybe to start with hair loss. So this might be, Tammy, if you were signed up for the program, you might say my most bothersome symptom is hair loss. And so Celia, if you want to kind of talk about how you might first address this.
Yeah. So we work through several different areas to think about your hormonal health, your nutritional health, make sure you're not inflamed in some capacity. And then we come up with a plan to sort of address that. It may be sort of these small twists over time, but we really, find that if we're able to sort of tackle all these things over the course of a couple of weeks, that a lot of times we see great results.
I think one of my most viewed Facebook Lives was on belly fat and chin hair and how the two are related, right? That metabolic change. I'm sure you guys, Paula and Anu, you see this a lot, right? Like that question. And it's a lot, to do a deep dive, but there are solutions.
Right.
I think I get a lot where if I go on HRT, will I lose the weight? That's the most common
question. And there's a lot of questions about weight and weight gain and sort of that connection between, as our hormones shift, as we move through our phases, into perimenopause and menopause, weight gain can be a side effect. It's complicated because there's many aspects that go into losing and gaining weight that hormones are definitely involved, but so are a lot of other things. And so it does take some discussion and work to figure out exactly what that is for that woman as to why they're gaining weight. Just like Lisa has commented, she'd like to lose weight and not be on so many medications. that's actually a really common thing that we hear a lot, right? Women, again, if you're working in kind of the traditional primary care office, such as in family medicine, a lot of the times we're disease focused. So we'll take a disease and then we'll say, oh, you have hypertension, and we'll put a medication to that disease just to treat your hypertension. But what we're trying to do is get to a place where we can get at the root of the problem, right? And maybe that is weight loss, figuring out why you're gaining weight. And we hope if we get into a good cadence, then we can maybe pull back on some of those other medications that we know are weight comorbidities.
So there was a study done that showed, why do people go to a clinic or an office that specializes in menopause? And there's two main complaints. Number one, I don't feel like myself. So that's not exactly a good problem base to start with. Like, it's pretty vague, right? But it's so real. And number two, I'm doing all the things. I'm exercising, I'm eating right, and I'm still gaining weight. And again, when I learned that menopause really increases insulin resistance, we know, for example, that women who take MHT, menopause hormone therapy, with estrogen and progesterone, or estrogen alone if you've had a hysterectomy, we know that it can help control blood sugars. It can help reverse insulin resistance. It gives you that window of opportunity that now the things can maybe take a better effect. We know that women who don't sleep gain weight. They become more insulin resistant. They gain weight that might crave. And so going on hormones all by itself might help a bit, but then it's putting everything together. We have a system, Sam, if you would put up the seeds. So the seeds are the 7 essential elements of daily success. And the habits are not treatment for menopause symptoms. They're a foundation. And so a lot of times we'll see women who are taking hormones and they're maybe not able to do all the things in terms of increasing their muscle mass, or we're not treating the insulin resistance. And sometimes that might take a medication for a bit, like metformin or a GLP-1. But again, it's addressing all those. So the seeds is certainly in a form on our website, and there's a seeds ebook, but it's all looking at these aspects. So these are those 7 habits. And again, a lot of you are probably doing all this, but then maybe then you might choose to add, if it's safe for you, you add estrogen and progesterone on top of this. And again, that's the trick, is how do we, number one, understand what you want, and then we are able to provide a personalized plan and follow along with your doctor on how it works for you.
And I think that's one of the really great things about the program, is just that it has, I don't want to say you're held accountable, but it's like the check-in is really important. And I think, my patients at my age, you get discouraged, right? You're doing all the things, the scale doesn't move. Like, you just need to see the number go down and you start feeling more motivated. And when you don't, you give up and you move on and you get more annoyed and irritated. And I think for this particular program, I think having access to you guys and all of the additional education and the check-ins regularly, it's kind of like how I always tell my patients, Weight Watch, you need somebody to hold you accountable for it. And I think that's a really important, really great part of this program. Is it's not, here's the information, go figure it out yourself. You guys are there to help them understand, do the labs, understand your labs, understand the plan. Why are you doing it this way? And I think that is a really invaluable thing for people, especially in the menopause age bracket, because I think, what you did up until this time that worked great for you, all of a sudden doesn't. And, Mary Claire Haver is always saying, like, that's why she got into all this in the first place, right? She was a runner and she was gaining weight and she didn't understand it. And when I talked to her about it at a conference once, she was just like, yeah, I never would have expected that it came to this, right? But she got the discussion going. And now I think it's great that we have people like you who can actually kind of coach them along in a sense.
Yeah, cool. I love Andrea's question. This is common. Will you offer hormone level testing and then solutions? So a couple little caveats. So sometimes, for example, for a woman who has an IUD or she's had a hysterectomy, we can't tell maybe her phase of ovarian function. Is she in early perimenopause? Is she in late perimenopause? Without some levels together with the story. The story really is key. Like, when do you get symptoms? Do you have symptoms? Like, what makes them worse? What makes them better? So hormone level certainly isn't the end all be all. And often, it's just a quick snapshot in time. But when we put it together, sometimes it can be helpful. We don't base dosing of treatment on a level. It's how do you feel within a safe range. So the hormones we recommend when people choose them are FDA approved, bioidentical. And those FDA approved bioidentical come in pretty set dosing. There's 5 doses for a patch. There's 2 doses for oral. And there's now an estrogen Premarin that's available with what's called a SERM or basodoxifene that can maybe even potentially reduce some risk factors for breast cancer. So when we look at dosing, it's, are you in a safe range and do you feel better? That's what matters. And so sometimes in perimenopause, we might say, let's get a level so you know that your symptom you have right now of acne, you're crying at the drop of a hat, and your breasts are like so tender you can't even stand it. You're probably having a super ovulation, making 5 eggs, and your estrogen might be 400. Okay, cool. I know what that is. I'm going to take the patch off. But now I'm irritable. I'm crying. I can't sleep. I have hot flashes. My estrogen level is 20. Okay. So again, we want you to know your body better than we do. We want you to know what to do when and to have those options available.
And I just want to note that definitely, I know there's a lot of programs out there that almost demand that you get a bunch of labs. You know, we do want some labs for overview of safety. We'll correlate that with the labs that you've already gotten done with your offices, with Together Women's Health. But we don't want this to be a program where women feel like, oh my gosh, I have to, cough up a couple thousand for all this different blood work to be done that we may not even utilize. So if we, that's always a conversation that we will have with patients about whether or not we think it makes sense to draw a lab. But we don't want women to be afraid that they can't get help unless they have a ton of labs, because I do know there are some programs like that.
Right. And the labs that we order tend to be with codes that insurance will pay for. You can get them done wherever you get your labs normally done. And they're pretty simple. It's rare that we need like what's called a Dutch test, which is a dried urine test. Very rarely women don't process estrogen well, and they need very tiny doses. And sometimes it's really validating. And so sometimes that's helpful. Sometimes Dr. Egan might want to do a deep dive into your lipoproteins and make sure, and what is your risk? We might order a calcium score of your heart to really know it's been 10 years since menopause. Is estrogen safe for you? So we go through a risk stratification in each of those areas of wellness to make sure that we're headed down the right path. And again, safety, we always say safety first, happy second.
I like that.
All right.
And so what other questions are here?
Janice
is asking, Celia, do you want to take this?
Well, I'm going to just talk. Kelly said, do we have to go through our OBGYN first to get the first appointment? So the answer to that question is no. If you go through your OBGYN's website, you can get a link to our practice and how to sign up if you are interested. Always feel free to run it by your OBGYN just to be sure that you're on the same page and that there's not a simple thing that you guys can talk about. But we're always happy to see anybody, and you don't have to wait for your next appointment before you can sign up.
And what happens is when we would see you, then we right away get a report of the visit to your doctor. So they know what's going on. We start to fill out a sheet called the Life Action Plan. So on the Life Action Plan is each category of wellness, what your goal is, where you are today, what your barriers are, and what the plan is. And so that goes right with a note with the Life Action Plan so they can see exactly. And then we work together to figure out if, potentially, let's say an IUD would be the best plan because you don't tolerate the certain progestin or you don't want that in your system, then you would see your doctor for that IUD, potentially see what they say, all that. So we work together, and that's how this works. We want this to be a partnership.
And so Janice asked a question. Not sure I understood, but is there a connection between weight gain and being pre-diabetic during menopause? So yes, there is. We find that the rates of pre-diabetes and type 2 diabetes go up as women sort of lose that hormonal sync with, thinking about controlling our blood sugars through our liver. A lot of the times, again, does become a snowball because as women are going through menopause, their cravings for sugary foods can go up. They're not sleeping as well. They're maybe feeling tired, so they're not exercising as much. We know all of that also leads to sometimes struggling with sugar. And so it kind of spirals out of control. And that's why it's really helpful to have someone sort of sort through all these different aspects to direct you in maybe the next best first step. And maybe we'll add on some other things as time goes on, but it can be really helpful to talk about where you want to be and where you're at, and finding sort of that bridge in the middle that we can get you started on the most effective way to get your blood sugars under control.
And Anu and Paula, I'm sure you guys see it all the time, like I used to, that women might have like even polycystic ovary, and then they get diabetes in pregnancy, and then, you know, weight gain happens and it starts to be frustrating, and then perimenopause. And, you know, the perimenopause can be really challenging for women with those underlying conditions already. I'm sure you see that a lot.
Yeah, definitely a lot. I find that they also, yes, we see that a lot. I apologize. I lost my train of thought.
No, that's okay.
Somebody had asked the question about what questions they should be asking. And, you know, I think just ask a question. I think sometimes when you're there for your annual and you've been going to your doctor for a while, and we're catching up on our kids and, you know, all the other things, and you can just say, like, what should I be watching for? And a lot of times the answer is everybody does it differently, but then it will generate a conversation. Are you having this symptom? Are you having that symptom? And I think perimenopause is difficult because it's very different for everybody. I mean, like menopause, but there's not set symptoms that people have. You know, when you're in menopause, people know, ask about hot flashes, ask about sleeping, and I think sometimes when you're having regular periods, you say there's no issues, sometimes the doctor will skip over that. So in terms of what questions should you ask, you can just literally say, what kind of things should I be looking for? Is there anything I can do to prepare for menopause? Those kind of questions are very normal and a good starting point for you to have with your OBGYN.
Yeah, and that's awesome. And another reason that's so cool to work with you guys is you're already interested in menopause and midlife. Like, you're already interested, and I've talked to a lot of you, and you guys talk about sexual health. And again, sometimes it's just that time factor. And so, you know, to work with you in terms of the conversation's already started, like people are just queued up, you know, then to go next step. So that's super exciting. Sam, I don't know if you can put up the symptom circle. So Paula, just to kind of tee off of what you said, we have the symptom circle that will come in that initial package, you know, when you sign up, or you can go on the website. Yeah, so Celia has it here. And it goes through what are the symptoms of perimenopause. So I invented that years ago when I was just trying to teach myself, like, what are the different factors that make it, that make a hot flash worse? It's not just hormones, right? It could be alcohol. It could be dehydration. It could be carrying extra weight that acts like a sweater that you can't take off. What's going on with the mood swings? You know, women with PMS or PMDD, they have way worse mood changes. Also interesting, there was a study done that's actually still ongoing called the SWAN study, the study of women across the nation. And it looked at women of Asian descent, of Hispanic, African-American, and Caucasian. And, you know, we all tend to experience symptoms differently, also based on socioeconomic status and education and, again, cultural background. But for example, women of color tend to experience hot flashes way earlier than any other group, more intense than any other group, and then they last a lot longer than any other group. And again, we see women who have prolonged hot flashes tend to have a higher risk of heart attack. So again, how those all go together are really, really interesting, but challenging. But again, having these solutions in our hand, again, we can better help, you know, where you get. And then there's a question like Lisa is saying, you know, mine is a tamoxifen belly. Well, what's tamoxifen? Women who take tamoxifen, right, it's an estrogen blocker. So it's a SERM, a selective estrogen receptor modulator. So it blocks those estrogen receptors, which then even triggers even more the insulin resistance and probably hot flashes and night sweats. So there's poor sleep. So it is an issue, but then again, we can still pick away. It wouldn't be safe to use estrogen, but we can pick away at why is your liver doing that?
And I think, even to answer McKatie's question, she's been in menopause for 17 years. Is it too late for treatment? We talk about certain timeframes that we've seen in the research studies of being 7 to 10 years, but all these questions are individualized questions that we want to have a good, risk versus benefit conversation with the patients. And I think that that's really impactful, because I think you start those conversations in your GYN visits, your annual GYN visits. And then if you need more details, we're always here to sort of give, maybe another layer and some extra time to talk about that.
Exactly. In the WHI, which was that study published in 2002 that really scared a lot of women away and a lot of doctors away. I was early in practice when that study came out, and my senior partner just said, stop prescribing. I was like, okay, I didn't even read the study. So, we in traditional medicine kind of dropped the ball on that. But now I know that study inside and out, as I'm sure you guys are comfortable and familiar with it. But what's really interesting is the only women who had complications, let's say heart attack or stroke, in that study, they were more than 10 years out from menopause. They already had heart disease or vascular disease that could cause a stroke. And they were on estrogen that made their blood sticky. So we no longer use estrogen that makes your blood sticky, except in the, potentially with Duo-V, for example. But we mainly use estrogen that's transdermal or bioidentical oral that doesn't make your blood sticky. And also we can test to see if you have plaque. The only women who had heart attacks in the study already had metabolic syndrome, which is obesity, diabetes, hypertension, and likely have significant plaque already. So if you are out from menopause and we can prove, and you jump through the hoops to say you don't currently have that. But again, a lot of women 17 years out probably might not need or do necessarily any better with systemic estrogen, but then we can talk local estrogen. So let's say estrogen in the vagina. There's a lovely product called Imvexy that is a little insert. Someone asked about the estrogen cream. It's very safe, the estrogen cream, but what makes the estrogen cream hard is, number one, it's in an alcohol base. So if you have really thin tissue already with cracks and it hurts, it's going to sting when you put it on, and you're going to wonder why your doctor gave you that. And then number two, it's hard to get the right amount, and it's messy. And so Imvexy is nice because it comes in a pre-measured little capsule, goes right in the vagina, it sticks, it melts, and a little coconut oil kind of is already a nice lubricant, moisturizer, and then the estrogen takes effect within 2 weeks. It's very safe. It's been shown to not even go into your blood, so it's safe even for women who have had breast cancer or met people who are on tamoxifen or aromatase inhibitors. Like, it's very safe, and it can treat painful intercourse, bladder infections, risk of urosepsis, like infection in your blood from a bladder infection. And so there's a lot of options. There's another option that's called Interosa, that's vaginal DHEA. So again, there's a lot of options.
And it's very exciting to have all those options. And I think, as time goes on, I think there'll be more and more of this stuff that comes out. And we really always hope to provide women with up-to-date messaging. So as, those recommendations change, women feel like they're in the loop. Gina, thank you for talking to us ladies. Just to let you guys know, this is a total virtual program. So all of it will be done virtually via telemedicine visits. And you will continue to see your gynecologist in the office in person. So I hope that answers that question.
Yeah. I mean, full disclosure, we're physically in Grand Rapids, Michigan. We're somewhere, right? So we're in Grand Rapids, Michigan, but this is a virtual program. And I do want to address Wendy Godwin. She's asked two questions. First of all, you're asking, what can you take that's not hormonal like factor 5? So actually, this is not just a simple yes or no. Some people with factor 5 who have not had an event, and especially if they're heterozygous, meaning they only have one copy of the gene, it can be safe to take estrogen, but definitely in a form that doesn't make your blood sticky. And that's definitely an informed consent conversation. We look at what are the risks, what are the benefits, and we make a decision together. So that thinking is a bit older in the sense of being a clear-cut yes or no. And also the thing that your cardiologist, Celia, if you want to take this, thinks I might need a GLP-1 because weight's creeping up.
Yeah. So for those who don't know, if your head's been in the sand, there's a new drug called a GLP-1, which is a type or a class of medications that has shown a lot of promise in not only type 2 diabetes, obesity medicine treatment, but we're seeing more and more data come out about vascular disease, preventing heart attacks or secondary heart attacks in people who've already had a cardiac event, and obstructive sleep apnea. And the data keeps pouring in about all the other sort of benefits that that class of medications, which will sort of dub the GLP-1s, have. The cardiology world sort of has locked on because of a couple of studies that have shown a decrease of the rate of heart attacks after a patient who's been on a GLP-1 seemed to have less, repeat heart attacks. So that may be why your cardiologist is excited about it. Definitely being in the obesity medicine world, we've seen significant results in terms of weight loss. And, for the most part, it's pretty well tolerated. The best thing is you got to find someone who knows how to use those medications appropriately. They're extremely potent. People can lose their desire to drink water, their desire to eat at all. And that's where we see a lot of side effects sort of pop in, like the constipation and the fatigue, and, hair loss can be another common thing if you don't get that nutritional piece right. So we really hope to, we do offer those as a treatment plan, if that sort of makes sense for a woman at any age that has, sort of meets criteria. And we really monitor those side effects closely. We want to make sure we're not sort of losing weight too fast, and we want to make sure patients are getting the appropriate nutrition. There's a synergy. There's one small study that showed a synergy between using menopausal hormonal therapy and the GLP-1, which was really exciting. And we hope to sort of continue to work together, merge these two worlds of the menopause world and the obesity medicine world to get like the best timing of these drugs, kind of right away.
And I see a question from Kate. If I'm in perimenopause, is HRT recommended? Kate, it can just be really tricky about, some women will be on, let's say they have an IUD and they're using a patch. It's like, when do I take it on? When do I take it off? So it can be safe. It's just really important to know when. And so we have texting 24/7. So in conjunction with your doctor in the office, we can answer those questions on the fly. Like, should I take my patch off? Should I put it on? Like when do I use what? We find that most women feel the effect of low testosterone a couple years after menopause, but for some women, they feel the effect before. And we do use FDA-approved testosterone following guidelines by the International Menopause Society. Again, your doctor in the office might know about that already, but it's really cool to put all of that together. I don't know what you guys think about that, but it's really been exciting that we now have guidelines. And for those of you who might have watched the FDA hearing on vaginal estrogen a couple weeks ago, testosterone was brought up as well. And a couple influencers like Kelly Casperson talks a lot about testosterone. So in perimenopause, it might be estrogen, progesterone, it might be progesterone alone for a while. So again, we've got lots of experience in all those pros and cons.
I think just to capitalize a little bit more about what you were saying about the study from 2002, because someone was asking, like, if you can't take hormones, the good thing that did come out of that study was that people became much more aware of what can we do to treat symptoms. And there are a very big subset of people who cannot take hormones for whatever reason, clotting, personal history of breast cancer. And the nice thing is that there are other medications now, but we can pinpoint it, prescribed medications for that might help with your hot flashes, or something that might help with, vaginal dryness, things that are available for you to use. And then in addition to that, companies have come out with very natural options. And so don't ever feel like you're backed in a corner that there's nothing you can do because you have these conditions, because a majority of the time there's been enough literature and studies and things done that we do have options for you that are safe.
Oh, I love that, Paula. And now we're really excited with a new class of therapies called the NKTs. So Veoza is out, and the company Astellas came out with that about a year ago, and Bayer hopefully very soon will have the FDA-approved product called Linquet. So they work on the thermostat just like estrogen does. They work the same. So estrogen is an antagonist for a hot flash starting. These NKTs are the same. So they work in the very same way that estrogen does. And they've been shown to improve hot flashes, night sweats, and Linquet has also been shown to improve sleep. So we're really excited to think that for women, even on tamoxifen or aromatase inhibitor who's got breast cancer, she's in active suppression after her treatment, these medicines are safe and very effective. So again, as these new medications roll out, and we know that Lexapro can be effective, Paxil is FDA approved for hot flashes. So I love how you bring that up.
And Lisa gave a shout out to Dr. Paula. Dr. Paula, you delivered my Nina 21 years ago. I love it, right? And Lisa, we just got to keep the care going on to this next phase.
And that's so exciting because, I've had patients who have gone to other programs online and they're like, I just want to still work with my doctor. And so this is cool that you can stay connected and you don't have to go outside of the family and you don't have to go away from your doctor.
Lisa,
now you guys are aging me.
What, Paula?
Now you guys are aging me.
I think I'm older than you. So
Lisa, I'm sure when Dr. Paula delivered your Nina, a lot of focus was probably on your Nina, but now we want the focus to be on you. What we can get to do to get you feeling as healthy as possible. Because we know all these ladies delivering babies, right? They're not necessarily always thinking about themselves when they're getting all this care from these wonderful OBGYNs.
Yes.
And Andrea, same here, being seen for her years, and she delivered my son. So fun.
Awesome. And Anu just delivered a baby an hour ago, right? And here you are. So comprehensive care of women. I see a question by Corinne. I do want to clear this up. If you had abnormal paps, but colposcopy comes back normal, can you use estrogen? So the cool thing is estrogen and progesterone don't have any effect on cervical cancer. In fact, it helps keep the cervix healthy and normal and would make paps even easier in the future. So I don't see any contraindication. So there's no worries about that.
Yes.
What's that?
I said, please use it.
I love that.
It makes paps better for everybody.
Yeah.
And Michelle Knight has a great question. My GYN prescribed me venlafaxine, 37.5 and then 75 milligrams afterwards, which is another common name is Effexor. We use that to treat hot flashes, but also sometimes anxiety and depression. She's a little concerned about using that. She's also concerned about also using hormonal replacement therapy. Michelle, you'd be a great candidate for us to help sort this out for you and truly give you all your options in terms of the risk and benefit, not only of these two drugs, the Effexor and the menopausal hormonal therapy, but maybe there's some other drugs that would make sense, like Dr. Bitner had gone through. So, it's so hard to know for sure what's the best drug for you without sort of hearing your story and your goals. But this would be you are our ideal patient that we would love to see to answer these questions for you.
And Michelle, to piggyback on that, a lot of times women are prescribed like Effexor or Lexapro, and they're like, it's a drug for depression, anxiety. I don't have anxiety or depression. Your doctor knows you don't, but these medicines work on the thermostat. So there's a thermostat in our brain that when everything is perfect, we have this comfort zone of 4 degrees. And when estrogen goes away, the comfort zone gets really narrow. So now you have a hot flash and you just crawled into bed with a nice blanket on and maybe your bed partner rolls closer, right? And boom, you have a hot flash. You never did before. So your comfort zone gets really narrow. Estrogen widens that comfort zone back so you don't have a hot flash when you're in bed. Effexor can help that comfort zone as well. It's not the most effective. An SSRI like Paxil or escitalopram, Lexapro is more effective. And now these NKTs are even more effective. And of course, estrogen is the gold standard for making that widen out. So, again, I see that a lot where people are prescribed these drugs and they're like, why? It's because it works on the thermostat, very similar to estrogen. Anu, do you want to answer this one? Not to put you on the spot. Does perimenopause look the same? Bill, a woman under the Bill Facebook.
Meaning the same for all the patients? Is that
for this person? She's had a partial hysterectomy.
Okay. Well, the symptoms can, if you still have your ovaries, you can still transition through menopause as if you, regardless of your uterus. So it can be similar, but I think the important thing to note is that menopause is different for every patient and every person individually. Some patients will start to have symptoms as early as, late 30s, even early, 40. Some patients will not have symptoms until their 50s. Some patients might not even have symptoms. And so like Paula was saying earlier, I think the important thing to do is make sure you ask the question. No question is too small or too dumb when you're experiencing it. So when you go to your gynecologist for your annual or your PCP, just make sure you ask the question to hopefully start the conversation.
Exactly.
Totally agree.
I saw a question about price. And so certainly price, is a question. Check out the website, see the pricing. But what's really interesting is that, sometimes it's like, why should I have to pay for care like this comprehensive care? And it's part of it, like to spend that time, that's just part of it. But what's really interesting is most women spend an average of $1,500 on supplements that might not be safe, they might not be effective, or it's the cooling blankets and it's the fans and it's the special pajamas and it's, all the things. And again, 10% of women will actually leave the workforce because of menopause, right? Like I've had patients who, I'm a teacher, I love what I do, I love the kids, I don't like the politics and the nonsense, and I have no patience anymore because I'm not sleeping and I'm snippy and I'm irritable and I don't want to get fired and maybe I just need to leave, right? Like you don't have to suffer, right? So it's like, in the end, how much does it really cost? Like menopause costs a lot in terms of the effect on your life and the supplements. So again, you do it for a year, you get everything lined up. Like it's just, hopefully we get you for years and years. But again, we want to get you feeling your best, and this care exists. And we're really hoping you take a close look at the Together Plus program.
And just to back that again, I know I said it before, but I have so many patients who go on these either platforms online or to some other functional medicine type people, and they're just spending thousands of dollars a month in the supplements alone without a lot of science behind it. So, you're going there every month. And I mean, some people are like, I can't even tell you how many things I'm taking because they're almost embarrassed about it. Right. And I feel like one thing that we always pride ourselves on is we practice good medicine, and there is a reason behind what we do. And I think when we partnered with you guys, that was one of the things we really liked, is you're not just trying to sell something with True Women's Health on it or just trying to get people to buy something that you're selling. I think that there's a real reason behind it. And I think the conversation with the patient and helping them to understand that is really huge too.
Cool. Thank you. I see a question by Lisa, feeling defeated because Zepbound was finally working for you and now insurance won't pay for it. One thing that we pride ourselves on is with Dr. Egan's help, we've really dialed in, how to do these meds. Celia, if you want to talk about that a little bit, from authorization to how to get them at an affordable.
And Lisa, I just want to say, I mean, the future is coming where it's so hard to believe these drugs won't be covered at some point because they're just so effective and beneficial in so many different aspects of disease management. So, fingers crossed that time is coming. What we found in the meanwhile, right, a lot of the times we can use some of the other anti-obesity medications to sort of bridge that gap until we can, find that Zepbound's more affordable. Of course, we need to make sure other aspects of your hormones are in line, and we would look at all of that if, as part of the conversation about getting you feeling your best.
So yes. And real quick, I just want to address Wendy. I see you've had an event 4 clots at once. We want you safe. So probably estrogen wouldn't be an option. But again, there's lots of things like Paula said, or Anu said, there's lots of things we can do to help you feel your best. Sorry you had to go through that, but we're good. Oh, look, Dr. Paula prescribed me, Kelly, Clomid 15 years ago and gave me my twin girls. Yay.
Such fun stories.
That's awesome. And the HSA, we see a lot of women, we can't tell you to use HSA or not, but a lot of women do, and we'll leave it at that. One thing we like to do, I see it's already 48 minutes. The time just flies on these, so we want to be respectful of your time. We always like to end with 5 takeaway tips. Is there anything else you guys want to add before I go into our tips?
No, I think I've been looking at all the comments, and I think we've addressed a lot of them.
Okay, cool. And usually we can get into a little bit more with this. So 5 takeaway tips. Number 1, you don't have to accept being miserable. There are options. So we've covered this a lot, but I see women who just like, again, that's one of the reasons we haven't talked about menopause as a whole, as a culture for so many years, because our moms, our grandmas just kind of dealt with it, right? They sucked it up. They had shame. I have a patient who was an auto exec, and she moved, over to the west side of Michigan, but she was an auto exec, and the guys would tease her like, "You have a HAFA, shouldn't you just go home? Like, why are you here? Why are you even still working?" So, it's been ridiculed, and so women would feel shame and just get quiet, and they would suffer. So you don't have to.
And remember, a lot of when a doctor is sitting there thinking, particularly maybe like a family medicine doctor who thinks less, traditionally about women's health, if you're so irritable and maybe you're not sleeping as well, that doesn't sometimes fit into that box that they have in their head of being an exact disease process. And so, it's always good to ask other questions, look to your, women health specialist, and maybe kind of get some more information about why you're feeling your best.
Yes. Oh, and Terry, real quick. Yes, I know Rachel Rubin well. She taught me how to do a clitoral hood reduction. So in terms of adhesions, getting rid of those. But Rachel's a good acquaintance. I see her at all the meetings. She's awesome. She did a great job on Peter Attia's podcast. Training. So I was a part of the study that looked at residents graduating from residency, and fewer than 10% of OBGYNs, internal medicine docs, and family practice docs are comfortable even talking about menopause. That's changing. Here in the state of Michigan, it is being introduced actually into the state budget that residents will be required to have menopause training. So, check us out with the Michigan Women's Commission. We're getting information about that, but it's really exciting. So it is true. But again, you've got doctors at Together Women's Health that know about menopause and are willing to work with you to help you. So it's a new world.
I think one of the things with training has always been, in general, there's just younger patients that are going to the resident clinics because a lot of it is OB driven. So it's not that there's not an interest, but like you're saying, it just there wasn't real time learning. And I think the nice thing is now that the conversation is out there so much, we kind of make it a bigger deal with our younger partners, just making sure when they get out there more comfortable with it too. But in all honesty, obviously, and I'm sure a lot of times women in menopause want to see women in menopause. And so I feel like, my older partners and I see a little bit more than the younger people, but they are getting education about it as well, which I think is great. Eventually, everybody's going to need to know more about it.
And what's exciting, like Rachel will say a lot that, when the WHA came out and hormones went away from, the toolbox of most doctors for a period of time because of misinformation, people stopped talking about menopause. Because if I don't have an option for you, then why talk about it, right? So then people went to Suzanne Summers on the compounded stuff.
Right.
So, and if you were trained by someone as a physician, you were trained by someone who is afraid of hormones, you're also going to be afraid of hormones. Right. And so, unfortunately, that whole group think was perpetuated. So here we are. But again, it's a new world. Okay, sorry. Tip number 2, menopause hormone therapy is safer than you think. Again, as Paula was saying, the WHI has taught us who is it safe for, who is it not. And it gives us guidelines to help make sure we're doing the right thing with these medications, as Celia said, are very powerful, very potent. And it's important that we do that risk-benefit analysis. But the WHI taught us it was a good study. It was just communicated poorly. It can be way safer than you think.
And there's so many options out there.
There are.
And
tip number 3, Celia, you want to take
know your symptoms, track what's changing in your body. You can use, online, we have what we call our menopause transition scale and our symptom circle available for anybody to sort of look through kind of the different symptoms that can come with perimenopause and menopause, just so you can sort of see where you're at. You may be surprised by what you learn about, putting some of these symptoms together. It can be helpful to track, once a week, once a quarter, just to sort of know what's changing in your body, particularly if you're in your 40s and early 50s, to understand where it's going. We know a lot of women have had a hysterectomy or IUD, so we can't rely on that traditional tracking with menstrual cycle changes. And we may need to use some of these other symptoms to pull them in to get some more information. So please feel free to check out our website and look at these tracking scales.
Yep, that MTS, it's an inventory. So you can actually track your symptoms and keep track of, are these therapies working for me?
Yeah.
Tip number 4. What is your picture of self? This is language we use to really help drive the conversation around what is your goal? How do you picture yourself at a future event or moving forward? So we want you all to think about, like, what do you want? And that's our goal. We're never going to tell you what to do. Our plan isn't about what we think you should do. It's about what do you want and how do we help you get there?
Awesome.
And tip number 5?
Know you are your best advocate and know your body best. Be honest with your providers about your symptoms and your preferences, right? If a doctor talks to you and sort of gives you a bit of a brush off, please feel empowered to seek out some other help from another physician that may have some more knowledge about how to help you. So that can be so impactful.
And then we always go through the 5 questions to ask at your Wellness Plus appointment. Number 1, what is my phase of ovarian function? Am I in late reproductive? Late reproductive is that phase where your periods are regular, but in the 3 days before your period starts, you might have a menstrual migraine, you might have mood changes, you might have poor sleep, you might have a night sweat. So that late reproductive phase is a phase where people say, I went to my family doc and they said, I'm too young for this. You're not too young for this, but it might happen for 2 months in a row and then it doesn't happen for 3 months. So it's one of those things that's just really important to understand. Am I in early perimenopause, late perimenopause? So again, having that defined can right away help us communicate. So if you choose to do the Together Plus program, like when you do that, we'll have it right in your chart. You're in late perimenopause, and it really helps us all to know what to expect and how to help you.
Number 2, what is your status of my metabolic health? So, your metabolic health is your body's ability to, take in and process food and move it to the right places. Should it be moving it into your muscle? Should it be storing it as fat? A lot of the times the disease processes we see from this can lead to the big time problems that people die from, right? Vascular disease, which is heart attacks and strokes. We know there's connections between metabolic health and dementia. Most women don't want to have those things. And so it all starts with taking care of that right, in midlife when we see these huge transitions that happen. I will say we diagnose patients with prediabetes all the time and women have no idea. So make sure when you're talking to your doctor that you ask that question. How's my metabolic health? Is my body processing sugars the way that it should, that's supposed to? And that's always a great question to know when you're in midlife.
And Lisa Lamb, you reminded me to share with you, we've created a whole platform on a platform called Mighty Network. So available to the Together Plus patients is this network that allows you to communicate and share your picture of self with everybody. It's a HIPAA protected platform. It's only internal to patients in Together Plus and True. And so it's a way to talk about and share, this is my picture of self, and to hear what other people are thinking. And those are all awesome goals, but they're also very reasonable. Like, you deserve that. So again, I look forward to working together and seeing that. And Missy, I'm sure you'll notice the question from Carolyn. What that
about making an appointment. Yeah,
what that's about. So Carolyn, we'll make sure and get to that and have an answer. So question number 3.
Am I a candidate for any anti-obesity medication? So anti-obesity medication are any drugs that help our body get into a weight losing state. There's the old ones that came out before the injectable medications that are effective, particularly for the right person. And then, of course, there's all the newer, what we'll call GLP-1, or we call it NUSH therapy, that's coming out. And honestly, guys, new ones are coming out almost every quarter in terms of there's going to be oral options, injections that instead of being once a week are going to be once a month. And that whole drug panel is going to continue to expand. You want to find someone who knows how to use these drugs appropriately, that's very familiar with the side effects. They're very potent and effective drugs, but you have to really make sure you're keeping up with your nutrition. So, this is obviously a long conversation to have with anyone who's considering an anti-obesity medication. And we always love to have that conversation with patients. So hope that was helpful.
Question number 4. What are my recommended screenings? Again, you guys seeing your doctors together, you're already getting a lot of these screenings, and you're already, I'm sure, on schedule. We then might add an extra, like a heart calcium score, which we believe every woman deserves to know. What is your status of heart disease today? So again, it's really individualized in terms of maybe even advanced screening for breast cancer. We can help with that. Help your doctor with that. But again, I'm sure you already, get a lot of that. It's just then adding those layers based on menopause and your metabolic health. And then the last question.
What signs and symptoms should I be aware of as I approach menopause, and how can being better informed help me prepare?
So, knowledge is power, right?
Yeah, knowledge is power. Again, check out the symptom circle if you have some new symptoms that you're a little concerned about. And it can be anything, right? Being a little more irritable, maybe just not sleeping as well. There can be even small little changes that can be correlated with these hormonal shifts.
Quick answer for Gail. It's kind of a personalized. She's asking how often should she have the calcium score?
Gail, there's official guidelines to sort of give it like mammograms, like there's very clear guidelines in terms of timing. A lot of that depends on what your initial score is and your risk factors. And that's a conversation that we have all the time. So we'd love to answer that question for you once we get more of your history.
Perfect.
Is there a recommended age for that too?
Again, a lot of it depends on family history and other findings. So for instance, if you are high risk for cardiovascular disease, maybe you have bad metabolic syndrome, or you're positive for, some of these newer high risk lipid findings, something called like lipoprotein a, then we may recommend doing it right away. Maybe if you're someone who's in surgical menopause early for whatever reason, that would be another reason why we get a sooner rather than normal calcium score. A lot of times women sort of in midlife, 40, 45, will talk about getting a calcium score if you have no other of these major risk factors.
I love the calcium score because it really helps with decision making. So let's say that your LDL starts to go up and your doc says, hey, let's go on a statin. It might be something that's more emergent, of course, if you have a positive score. Again, Celia's the expert, but sometimes maybe there's 6 months where you can really focus on lifestyle or red yeast rice or whatever, right? But it just really helps with decision making. Or do we need to check like a lipoprotein level and see, do you have a high lipoprotein A? Like, it can really help us with decision making rather than you getting a standard answer of, right? So it just helps us know more and be better able to personalize the plan for you. So I do want to remind you all on the 21st, August 21st, we will be having a focused program on the weight plus journey. Celia, I don't know if you want to talk briefly about that.
Yeah. So if you're someone who's like, all I really need help with is sort of weight management, we'll be talking a little bit more in detail about, again, why bodies gain and lose weight and some of the treatment options that are out there, including some lifestyle changes that we tend to see that work more in menopause. You can get some more information then.
So if you text this number, the 616-200-7675, you'll be contacted with one of the Together Plus staff, and they'll make an appointment to answer your personal questions about the program, what this might mean for you, how it works with any of those other details. So that would be the number. If you want more information versus just going on the website, that would be how you do it. And again, we hope to see you on August 21. We really thank you for joining us. Paula and Anu, I can't thank you enough for coming on, because this is a team, this is a partnership. We're working together, and we're so excited that we get to reach more people together.
Same.
Thank you. It's been valuable, very valuable.
Awesome.
Right.
Thanks
so much.
Thank you. Okay, have a good night, everyone.
Hey.